The emergency room at Riverside General was chaotic. Ambulances screamed into the bay as paramedics wheeled in victims from the multi-car pileup on Interstate 85. Dr. Rebecca Chen moved between gurneys with practiced efficiency, but when the trauma alert sounded for the worst case, a construction worker with severe abdominal injuries, everyone turned to look for the most experienced surgeon available. Before we jump back in, tell us where you're tuning in from. And if this story touches you, make sure you're subscribed because tomorrow I've saved something extra special for you. "Where's Martinez?" someone shouted over the noise. "Still in surgery," came the reply. "We need someone else." Eyes scanned the room and landed on Dr. Sarah Brennan, the newest addition to the trauma team. At 28, she looked even younger, with blonde hair pulled back in a simple ponytail and wire-rimmed glasses that gave her an almost scholarly appearance. She'd been at Riverside for only 6 weeks. "Brennan's here," Dr. Chen called out, but her voice carried obvious hesitation. Dr. James Whitaker, the chief resident, shook his head immediately. "She doesn't have the experience for something this complex. This guy's bleeding out. We need someone who's handled battlefield trauma before." Sarah stood quietly by the supply cabinet, her hands steady as she pulled on surgical gloves. She'd heard variations of this conversation countless times since arriving at Riverside. The other doctors saw her resume: medical school at Northwestern, residency at a quiet suburban hospital in Colorado, fellowship in general surgery. Nothing that screamed trauma specialist. The patient was rushed into Trauma Bay 3, and Sarah followed despite the murmured concerns echoing behind her. Marcus Thompson, 34 years old, had been crushed when his excavator rolled during the highway construction accident. His vital signs were dropping fast, blood pressure barely registering. "Multiple penetrating wounds to the abdomen," the paramedic rattled off his report. "Possible internal bleeding, suspected damage to major organs. He's been unconscious since we pulled him from the wreckage." Dr. Whitaker stepped forward, clearly intending to take over, but Sarah was already at the patient's side, her hands moving with surprising confidence as she assessed the injuries. Her fingers traced the wounds with the kind of precision that comes from muscle memory built under extreme pressure. "I need 2 units of O-negative, stat," she called out, her voice cutting through the noise with unexpected authority. "And get me a surgical tray. We're going to need to open him up here before we lose him." "Brennan, maybe you should step back and let—" Whitaker began, but Sarah was already making her first incision with the kind of swift, decisive movement that made everyone in the room pause. The attending nurses, who had initially looked skeptical, found themselves responding to her commands without question. There was something in the way she worked, an economy of motion, a calmness under pressure that didn't match her apparent lack of experience. "Jesus," whispered Jennifer Torres, one of the senior nurses, "look at her hands." Sarah's technique was flawless. She navigated the complex abdominal cavity like she'd done it hundreds of times before, identifying damaged organs and severed blood vessels with an accuracy that left the other doctors speechless. When she encountered a particularly challenging bleed near the liver, instead of calling for help, she adjusted her position and attacked the problem with a technique that was both unconventional and incredibly effective. "Where the hell did she learn to do that?" Dr. Chen muttered to Whitaker, who was now watching with growing amazement instead of preparing to intervene. The surgery took 3 hours. Marcus Thompson's injuries were worse than initially thought. His spleen had been lacerated, his left kidney damaged, and several major blood vessels torn. But Sarah's hands never wavered. She worked with the kind of focused intensity that comes from having faced life-or-death situations before, lots of them. When she finally stepped back from the table, having successfully stabilized the patient and repaired the most critical damage, the trauma bay was unnaturally quiet. Marcus's vital signs were steady, his color improving. He would live. "Nice work," Dr. Whitaker said, though his tone suggested he was still processing what he'd just witnessed. Sarah simply nodded and began stripping off her surgical gown. "He'll need monitoring for the next 24 hours. Watch his kidney function especially." As she turned to leave, Dr. Chen noticed something. The surgical gown had ridden up slightly, exposing Sarah's forearms. What she saw made her do a double take. "Sarah," she called out, "wait a second." Sarah paused, her hand on the door handle. "Those scars on your arms," Chen continued, her voice quieter now, "those aren't for medical school accidents, are they?" The room grew still. Everyone was looking now, though most couldn't see what Dr. Chen had noticed. Sarah's forearms, normally hidden beneath long sleeves, bore a distinctive pattern of small, irregular marks, the kind left by metal fragments traveling at high velocity. Sarah's jaw tightened almost imperceptibly. For a moment, she looked like she might simply walk out without answering. The confident surgeon who had just saved Marcus Thompson's life suddenly seemed smaller, more guarded. "I don't know what you mean," she said finally, but her voice lacked conviction. Dr. Whitaker stepped closer, his earlier skepticism replaced by curiosity. "Those look like shrapnel scars, Brennan. I've seen them before on the military trauma patients we get from the VA." "My background is civilian medicine," Sarah replied, pulling her sleeves down. "You have my resume." But Jennifer Torres, the nurse who had first noticed Sarah's unusual surgical technique, was studying her with new eyes. "That move you used to control the hepatic bleeding," she said slowly. "I've only seen that done once before, by a Navy surgeon who'd just come back from deployment. He said it was something you learned when you had to operate in the field, when you didn't have all the equipment you needed." Sarah's hand was still on the door handle, but she hadn't moved to leave. The silence stretched out, heavy with unasked questions. "Look," Dr. Whitaker said finally, his voice gentler than before, "I don't know what your story is, and maybe it's none of our business. But what you just did there, that wasn't the work of someone who learned surgery in a quiet Colorado hospital. That was combat-level trauma work." Sarah turned around slowly, her blue eyes meeting him for the first time since the surgery ended. For just a moment, something flickered across her face, a glimpse of experiences that went far beyond anything in her official medical record. "Some things aren't meant for resumes," she said quietly. The machines monitoring Marcus Thompson continued their steady beeping, the only sound in the otherwise silent trauma bay. Sarah looked at each of their faces, Dr. Chen with her obvious curiosity, Whitaker with his growing respect, Jennifer Torres with the knowing look of someone who was starting to piece together a much larger puzzle. "I need to check on my other patients," Sarah said, and this time she did leave, pushing through the door and disappearing into the hospital corridor. Behind her, the trauma team stood in contemplative silence. They had witnessed something extraordinary, not just exceptional surgical skill, but the kind of practiced competence that comes from having faced horror before and survived it. Dr. Chen was the first to speak. "Those weren't just shrapnel scars," she said thoughtfully. "They were old ones, healed, but deep." "And that technique," added Jennifer Torres, "the way she approached that liver bleed, I'm telling you, I've only seen that from surgeons who've operated in war zones." Dr. Whitaker nodded slowly, his mind already racing with implications. "So the question is," he said, "where exactly did Dr. Sarah Brennan learn to save lives under fire?" The next morning brought an unusual quiet to Riverside General's trauma unit. Word had spread overnight about the new surgeon's remarkable performance, though the details remained frustratingly vague. Sarah Brennan arrived for her shift at 6 a.m., moving through the hospital corridors with the same measured pace she'd maintained since her first day. But things are different now. Conversations stopped when she passed. Nurses who had previously offered polite but distant greetings now watched her with open curiosity. The maintenance staff, who knew everything that happened in the hospital before the doctors did, whispered among themselves about the surgeon who had saved the construction worker with techniques they'd never seen before. Sarah seemed oblivious to the attention, or perhaps she was simply accustomed to ignoring it. She reviewed her patient charts with meticulous precision, checking on Marcus Thompson first. His recovery was progressing better than expected. His kidney function had stabilized overnight, and the complex repairs she'd performed showed no signs of complications. "How's our miracle patient?" Dr. Chen asked, appearing beside her at the ICU monitoring station. "He's responding well," Sarah replied, her tone professional and neutral. "The liver repair is holding, no signs of internal bleeding. He should be ready to move to a regular room by this afternoon." Dr. Chen studied her colleague's profile, noting the same careful composure that had characterized Sarah since her arrival. "You know, I've been thinking about yesterday," she said carefully. "That hepatic arterial control technique you used, it's not something they teach in standard surgical programs." Sarah's fingers paused briefly over the keyboard where she was entering her notes. "Trauma surgery requires adaptability," she said simply. "Sometimes you have to improvise." Preparing and narrating the story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now, back to the story. "Improvise, sure," Chen continued, "but that wasn't improvisation. That was muscle memory. You've done that exact procedure before, haven't you?" Before Sarah could answer, Dr. Whitaker approached their station, a tablet in his hand and an expression of barely contained excitement on his face. "Brennan, I need to talk to you," he said, his voice low but urgent. Sarah looked up from her charts, her blue eyes guarded. "What about?" Whitaker glanced around the ICU, noting the proximity of other staff members. "Not here. Conference room B, 5 minutes." He walked away without waiting for a response, leaving Sarah and Dr. Chen alone at the monitoring station. Chen watched her colleague's face carefully, noting the slight tightening around her eyes, the first crack in her carefully maintained composure. "What do you think that's about?" Chen asked. Sarah closed the chart she'd been reviewing with deliberate precision. "I suppose I'll find out." Conference Room B was a small, windowless space, typically used for private discussions between doctors and families. When Sarah entered, she found not only Dr. Whitaker waiting, but also Dr. Elizabeth Morrison, the head of the trauma department, and Captain Michael Rodriguez from the Veterans Affairs Liaison Office. The presence of the VA representative immediately put Sarah on edge. She remained standing near the door, her posture straight but ready to leave at a moment's notice. "Dr. Brennan," Dr. Morrison began, her tone carefully neutral, "please have a seat." "I'm fine standing," Sarah replied. Captain Rodriguez, a stocky man in his 50s with graying hair and perceptive dark eyes, leaned forward in his chair. "Dr. Brennan, I've been reviewing some information that's come to my attention regarding your background." Sarah's jaw tightened almost imperceptibly. "My credentials are all properly documented and verified." "Oh, your medical credentials are impeccable," Rodriguez agreed. "Northwestern Medical, excellent residency performance in Colorado, solid fellowship completion. But there's something interesting about the timeline." He opened a manila folder and spread several documents across the conference table. Sarah didn't move to look at them, but from her position by the door, she could see they appeared to be official forms and photographs. "You see," Rodriguez continued, "there's a gap in your documented history, 3 years, from 2018 to 2021, where your whereabouts are surprisingly difficult to trace through normal civilian channels." Dr. Whitaker looked between Rodriguez and Sarah, clearly not entirely sure what was happening, but invested in the outcome. "What kind of gap?" he asked. "The kind," Rodriguez said, still watching Sarah's face, "that often corresponds with classified military deployment records." The room fell completely silent, except for the soft hum of the air conditioning system. Sarah remained motionless by the door, her expression giving nothing away, but her hands had moved slightly behind her back, a defensive posture that Rodriguez recognized immediately. "Dr. Brennan," Dr. Morrison said gently, "if you have military medical experience, that's not a problem. In fact, it would be an asset to our trauma program. We're just trying to understand your background better." Sarah looked directly at Rodriguez. "What exactly are you implying, Captain?" "I'm not implying anything," he replied. "I'm stating that based on what I witnessed in the security footage from yesterday's surgery, combined with certain inquiries I've made through appropriate channels, I believe you served as a field surgeon in a combat zone, most likely Iraq, possibly Syria, given the time frame." The silence stretched out again. Dr. Whitaker shifted uncomfortably in his chair, while Dr. Morrison watched Sarah with growing understanding. "The way you handled that abdominal trauma," Rodriguez continued, "the specific techniques you used, the calm under extreme pressure, those are skills developed in very particular circumstances, combat circumstances." Sarah moved away from the door for the first time since entering the room, walking slowly to the window that looked out over the hospital parking lot. Her reflection in the glass showed a young woman who suddenly looked much older than her 28 years. "What do you want from me?" she asked finally, her voice quiet but steady. "Nothing," Rodriguez said immediately. "I want to help. If my suspicions are correct, you've served your country in ways that most people can't imagine. The medical corps personnel who work in forward operating bases and combat support hospitals, they see things, do things that stay with them long after they come home." Sarah looked away from the window, her blue eyes now showing something that hadn't been there before, a weariness that went deeper than physical exhaustion. "What do you want from me?" she asked finally, her voice quiet but steady. "Nothing," Rodriguez said immediately. "I want to help. If my suspicions are correct, you've served your country in ways that most people can't imagine. The medical corps personnel who work in forward operating bases and combat support hospitals, they see things, do things that stay with them long after they come home." Sarah turned from the window, her blue eyes now showing something that hadn't been there before, a weariness that went deeper than physical exhaustion. "What do you want from me?" she asked. Rodriguez smiled slightly. "Then I apologize for an old soldier's overactive imagination, and we all go back to our regular duties." Dr. Morrison leaned forward in her chair. "Sarah, the reason we're having this conversation is because what you did yesterday was extraordinary. We've all worked in trauma for years, and we've never seen anything quite like it. If you have experience that could benefit our program, our patients, we'd like to know about it." Sarah walked to the conference table and looked down at the documents Rodriguez had spread out. Among them was a photograph that made her pause, a group of military personnel in desert camouflage standing in front of what appeared to be a mobile surgical unit. "Where did you get this?" she asked, her voice barely above a whisper. "From a contact at the Pentagon," Rodriguez replied. "Took some convincing, but they eventually confirmed that this was taken at Forward Surgical Team Alpha 7, approximately 15 kilometers outside of Ramadi, Iraq, in 2019. Sarah picked up the photograph, her hands trembling almost imperceptibly. In the center of the group was a younger version of herself, wearing military fatigues and a serious expression, standing next to surgical equipment that looked nothing like the pristine facilities at Riverside General. "That was a different life," she said finally. Dr. Whitaker found his voice. "How different?" Sarah set the photograph back down on the table, but continued looking at it. "Different enough that I don't talk about it. Different enough that it's not on my resume. Different enough that most people wouldn't understand what it was like." "Try us," Dr. Morrison said gently. Sarah was quiet for a long moment, her gaze fixed on the photograph. When she spoke again, her voice carried a weight that made everyone in the room listen more carefully. Forward Surgical Team Alpha 7 was a mobile surgical unit that operated in some of the most dangerous areas of Iraq during the final years of active combat operations, she began. "We worked out of converted shipping containers, abandoned buildings, sometimes just tents. We had minimal equipment, inconsistent power, and we treated everything from routine injuries to massive trauma from IEDs, gunshot wounds, and rocket attacks." She paused, her fingers unconsciously rubbing the scars on her forearms that Dr. Chen had noticed the day before. "The hepatic arterial control technique you asked about," she continued, looking at Dr. Whitaker, "I learned that during a 48-hour period when we had 17 casualties come through our facility, including 3 with severe abdominal wounds. We were running low on surgical supplies, the power kept cutting out, and we were taking intermittent mortar fire. You learn to adapt quickly under those conditions." Rodriguez nodded slowly. "How many tours did you complete?" 2, Sarah replied. The first was 18 months, the second was 14 months. I came back in 2021. And then? Dr. Morrison asked. Sarah's expression became guarded again. And then I needed to become someone else for a while. Someone who fixed people in quiet hospitals in Colorado instead of someone who tried to put soldiers back together while explosions went off outside. The room was completely silent now. Everyone was beginning to understand that they weren't just looking at a talented surgeon. They were looking at someone who had experienced things that most people would never face. The scars on your arms, Dr. Chen had mentioned, Rodriguez said. When did that happen? Sarah's hand moved involuntarily to her forearms, then stopped. March 15, 2020. We were operating on a wounded Marine when our facility took a direct hit from a rocket-propelled grenade. The explosion sent shrapnel through the surgical suite. 3 of us were injured, but we managed to keep the patient alive. She looked up at the others in the room, her blue eyes now showing a depth of experience that made her earlier perceived inexperience seem almost absurd. That's why I don't talk about it, she said simply. Because once people know, they look at you differently. They see the combat veteran instead of just the doctor. They assume you're damaged or dangerous or can't handle civilian life. Dr. Morrison shook her head. What I see is someone who has skills and experience that could save more lives than I can count. What I see is someone who chose to come home and continue serving, just in a different way. Sarah looked around the room at the faces watching her. Dr. Whitaker with newfound respect, Captain Rodriguez with the recognition of one veteran acknowledging another, Dr. Morrison with the appreciation of a department head who had just discovered an incredible asset. So what happens now? Sarah asked. Dr. Morrison was the first to respond to Sarah's question, her voice carrying the authority of someone who had spent decades making difficult decisions in high-pressure situations. What happens now is that you continue doing exactly what you've been doing, she said firmly, saving lives. The only difference is that we now understand why you're so exceptionally good at it. Captain Rodriguez closed the manila folder and leaned back in his chair. Dr. Brennan, I want you to know that your service record, what I was able to access, is exemplary. Forward Surgical Team Alpha 7 had one of the highest save rates of any mobile surgical unit in the theater. The commanding officers I spoke with described your work as miraculous under impossible circumstances. Sarah's expression remained carefully neutral, but something flickered in her eyes, a mixture of pride and pain that suggested those memories came with a significant cost. That was a team effort, she said quietly. I wasn't there alone. No, Rodriguez agreed, but according to Major Patricia Hayes, who was your commanding officer during your second tour, you performed over 400 major surgical procedures under combat conditions. That's more experience with traumatic injuries than most civilian surgeons see in their entire careers. Dr. Whitaker had been listening intently, and now he spoke up with obvious excitement. Sarah, do you realize what this means for our trauma program? The techniques you used yesterday, the way you approached that complex abdominal case, if you could teach that to our other surgeons, we could revolutionize how we handle severe trauma cases. But Sarah was already shaking her head. I came to Riverside to practice quiet medicine, routine surgeries, scheduled procedures, patients who come in for gallbladder removals and hernia repairs. I didn't come here to relive combat surgery. But yesterday wasn't routine, Dr. Morrison pointed out, and you didn't hesitate. When that construction worker needed you, everything you learned in Iraq came out automatically. Sarah walked to the other side of the conference room, putting distance between herself and the others. That's exactly the problem. I spent 2 years learning to turn that off, to be a normal doctor in a normal hospital. One emergency case, and it all comes flooding back. The room fell quiet again, but this time the silence was charged with tension. Everyone could see the internal struggle playing out across Sarah's face. The highly trained combat surgeon she had been, and the civilian doctor she was trying to become. Captain Rodriguez stood up and moved to join her by the far wall. Dr. Brennan, can I speak frankly? Sarah nodded without looking at him. "I've worked with a lot of veterans transitioning back to civilian life," he said, his voice low enough that the others had to strain to hear. "Medical personnel especially. And I've learned that trying to completely separate yourself from your military experience is like trying to pretend you never learned to walk. It's part of who you are, part of what makes you exceptional at what you do. It's also part of what makes me wake up some nights thinking I'm still there," Sarah replied, finally turning to face him. "Part of what makes me check every room for exits, part of what makes me flinch when helicopters fly overhead. You want to talk frankly? Some days I can barely function in a civilian hospital because every trauma alert makes me expect incoming wounded from an IED attack." The raw honesty in her voice made everyone in the room uncomfortable. Dr. Morrison and Dr. Whitaker exchanged glances, suddenly understanding that they were dealing with something far more complex than just a surgeon with unusual skills. "Have you sought any help for that?" Dr. Morrison asked gently. Sarah's laugh was bitter. "Help from whom? Civilian therapists who've never been in a war zone? VA counselors who are overworked and understaffed? Support groups where everyone wants to compare trauma stories?" She walked back to the conference table and picked up the photograph of her military unit again. "Do you know what happened to Forward Surgical Team Alpha 7 after I left?" No one answered. 3 months after my tour ended, they were overrun during a coordinated attack on their forward operating base. Dr. Kevin Walsh, who took over my position, was killed along with 2 of our corpsmen. Jennifer Kim, who was our anesthesiologist, lost her left leg to an IED while they were evacuating patients. She set the photograph down with deliberate care. "So forgive me if I'm not eager to embrace my military medical experience. Some things are better left in the past." Captain Rodriguez returned to his seat, but his expression remained thoughtful. "With respect, Dr. Brennan, your friends didn't die so that you could hide from what you learned. They died serving, and they'd probably want you to keep serving in whatever way you can. Don't." Sarah's voice was sharp, cutting through the air like a scalpel. "Don't you dare tell me what my dead friends would have wanted." The room temperature seemed to drop several degrees. Dr. Morrison realized they had pushed too far, too fast. "Sarah," she said carefully, "no one is asking you to go back to combat medicine. What we're suggesting is that your experience could benefit the patients here in a safe, controlled environment." "There's no such thing as a controlled environment when someone's life is on the line," Sarah replied. "Yesterday proved that. 1 minute I'm planning to assist on a routine appendectomy, the next minute I'm elbow deep in someone's abdomen trying to stop them from bleeding out on the table." Dr. Whitaker leaned forward, his enthusiasm barely contained despite the tension in the room. "But you saved him, Sarah. Marcus Thompson is alive because of your training, your experience. How many other people could you save if you embraced that instead of fighting it?" Sarah stared at him for a long moment, then looked around the room at each of them in turn. "You want to know the truth about combat surgery? It's not heroic. It's not glamorous. Most of the time, you're trying to do the impossible with inadequate resources while people around you are dying." She moved to the whiteboard at the front of the room and picked up a marker, beginning to draw a rough diagram. "This is what our surgical suite looked like in Ramadi," she said, sketching quickly. "Converted shipping container, barely enough room for 2 operating tables. We had 1 working autoclave, backup generators that failed regularly, and blood supplies that sometimes didn't arrive for days at a time." The others watched as she added details to the diagram: supply closets that were actually just metal shelving, a triage area that was nothing more than space on the floor, equipment that had been jury-rigged to keep functioning in desert conditions. "We had a saying," she continued, still drawing, "good, fast, and cheap, pick 2. Except in combat surgery, you don't get to pick. You have to be all 3, all the time, or people die." She turned back to face them, the marker still in her hand. "The hepatic arterial control technique you were so impressed with yesterday, I learned it because we ran out of proper surgical clamps during a mass casualty event. I had to improvise or watch a 19-year-old Marine bleed to death." Dr. Morrison was beginning to understand the depth of what Sarah had experienced. "How many soldiers did you treat?" "I stopped counting at 800, Sarah replied, "but I can tell you exactly how many we lost. 43. I remember every single one of their names, their ages, what happened to them." She walked to the conference table and sat down for the first time since entering the room, suddenly looking exhausted. "Private David Chen, 19, IED blast, multiple amputations. We couldn't get him stable enough for evacuation. Sergeant Maria Santos, 24, gunshot wound to the chest, developed complications during surgery. Lieutenant Michael Brooks, 22, vehicle rollover, internal injuries we couldn't detect until it was too late." The room was completely silent as Sarah continued listing names, ages, causes of death. It was clear she had carried this information with her for years, a mental monument to the patients she couldn't save. "So, when you ask me to embrace my military medical experience," she said finally, "you're asking me to embrace the memory of 43 people I couldn't help, along with the few hundred I could." Captain Rodriguez spoke softly. "But you did help a few hundred. That's what matters." Sarah looked at him with eyes that had seen too much. "Is it? Because most nights I only dream about the 43. Dr. Morrison reached across the table and placed her hand over Sarah's. "Sarah, what you're describing sounds like survivor guilt, possibly PTSD. There are treatments, therapies that can help." "I've tried therapy," Sarah replied. "Tried medications, tried meditation, exercise, changing careers, moving across the country. Nothing makes it go away completely. The best I can do is manage it, contain it, try to be a normal doctor in a normal hospital where the worst case I see is someone who needs their appendix removed." "But yesterday proved that's not sustainable," Dr. Whitaker pointed out. "When a real emergency happens, all of your training and experience comes out anyway. Instead of fighting it, maybe you should find a way to use it constructively." Sarah was quiet for a long time, staring at the diagram she had drawn on the whiteboard. Finally, she spoke. "What exactly are you proposing?" Dr. Morrison sensed an opening and chose her words carefully. "What if we created a position that would allow you to use your trauma experience when it's truly needed, but also give you the routine cases you want? A hybrid role where you could help train our other surgeons in advanced trauma techniques, but primarily work on scheduled, non-emergency procedures." "And when cases like Marcus Thompson come in?" Sarah asked. "You'd be available if you wanted to be," Morrison replied. "No pressure, no requirements, just an option." Sarah considered this for several minutes, everyone in the room waiting for her response. Finally, she stood up and walked to the whiteboard, adding one more element to her diagram of the combat surgical suite, a small symbol in the corner. "That's the unit insignia for Forward Surgical Team Alpha 7, she explained. "Our motto was Salvare Vitas, save lives. It didn't matter where we were, what conditions we were working under, or how scared we were. Our job was to save lives." She turned back to face the others. "Maybe the location has changed, but the mission is still the same." Captain Rodriguez smiled slightly. "So, you'll consider Dr. Morrison's proposal?" Sarah nodded slowly. "I'll consider it. But I have conditions." "Name them," Morrison said immediately. "First, my military record stays classified. What we've discussed in this room doesn't leave this room. I don't want to become the poster child for veteran surgeons." "Agreed." "Second, I maintain my regular surgical schedule. The trauma work is supplemental, not primary." "Understood." "Third," Sarah paused, looking around the room one more time. "If I have a bad day, if the memories become too much, I need to be able to step away without questions or judgment." Dr. Morrison nodded. "Absolutely. We'll make sure you have all the support you need." Sarah walked to the door, then stopped and looked back. "There's one more thing you should know. The reason I really left the military wasn't just burnout or PTSD." Everyone waited. "I left because I started making decisions based on who I thought deserved to live more than others. When you see that much trauma, that much senseless violence, you start categorizing victims. The kid who was just in the wrong place at the wrong time versus the soldier who ignored safety protocols. The local civilian versus the enemy combatant who got caught in crossfire. Her voice was steady, but her hands were trembling slightly. That's not medicine. That's playing God. And the day I realized I was doing it was the day I knew I had to come home. She opened the door to leave, then paused one more time. If I'm going to do this, if I'm going to use what I learned over there to help patients here, I need all of you to understand that I'm still figuring out how to be human again. Some days are better than others. As the door closed behind her, the 4 people remaining in the conference room sat in contemplative silence, each processing what they had just learned about their colleague in very different ways. 2 weeks passed before the hospital faced its next major crisis. During that time, Sarah had settled into an unusual routine. Mornings spent on scheduled surgeries, afternoons consulting on trauma protocols, and evenings reviewing case studies with younger residents who were eager to learn from someone with her experience, even if they didn't fully understand the source of her knowledge. The arrangement seemed to be working. Sarah's PTSD episodes had decreased in frequency, partly because she was no longer fighting against her training, but finding controlled ways to use it. She had begun sleeping better, though the nightmares never completely disappeared. Dr. Morrison had been true to her word about keeping Sarah's military background confidential, but word had still spread through the hospital's informal networks. The maintenance staff whispered about the surgeon who had saved Marcus Thompson with techniques they'd never seen. The nurses talked about her unusual calm during emergencies. The residents sought her out for advice on complex cases, drawn to her expertise, even without knowing its origins. It was a Tuesday evening when everything changed again. Sarah was in the hospital cafeteria, finishing a late dinner while reviewing surgical notes, when the emergency alert system crackled to life throughout the building. Code Gray, all units, mass casualty event, multiple vehicle collision with fire, Interstate 85 southbound, ETA 7 minutes. All available trauma staff to the emergency department immediately. The announcement repeated twice more as Sarah gathered her things and headed toward the elevator. Code Gray meant at least 5 serious casualties, possibly more. As she walked through the corridors, she could see the familiar choreography of a hospital preparing for the worst. Nurses securing equipment, residents checking supply levels, administrators coordinating with paramedic services. But when Sarah reached the emergency department, she found chaos beyond anything Riverside General had experienced in recent memory. 23 vehicles involved, Dr. Chen was saying to Dr. Morrison as Sarah approached. A tour bus collided with a fuel tanker, causing a chain reaction. Initial reports suggest at least 15 critical injuries, possibly more. How many trauma bays do we have available? Morrison asked. 4 fully equipped, 2 more we can jury-rig if necessary, came the reply from Jennifer Torres, who was coordinating the nursing staff. Sarah listened to the logistics discussion while her mind automatically began calculating resources, time requirements, and triage priorities. It was a mental process she had hoped to never use again, but it activated now with disturbing clarity. Dr. Morrison, she said quietly, approaching the group, based on what you're describing, 4 trauma bays won't be enough. Morrison turned to her. What do you suggest? Sarah looked around the emergency department, her experienced eye cataloging every available space, every piece of equipment. We need to set up overflow treatment areas. The waiting room can be cleared and converted to handle less critical cases. The hallway outside trauma can accommodate stretchers for assessment and stabilization. The waiting room, Dr. Whitaker had joined them and looked skeptical. That's not a sterile environment. Sterile is a luxury when you have this many casualties, Sarah replied, her voice taking on the authoritative tone she had used in Iraq. The choice isn't between perfect conditions and good conditions, it's between improvised treatment and no treatment at all. The first ambulance arrived before anyone could respond to her suggestion. The paramedics rushed in with a middle-aged woman who had suffered severe burns and smoke inhalation. "Trauma 1," Dr. Chen called out, directing them to the first bay. The second ambulance was 30 seconds behind the first, bringing in a teenage boy with multiple fractures and possible internal bleeding. "Trauma 2," Morrison directed. By the time the third ambulance arrived, followed immediately by the fourth and fifth, it was clear that Sarah's assessment had been correct. The traditional trauma-based system was already overwhelmed. "Clear the waiting room, now!" Morrison shouted to the nursing staff. "Set up triage stations like Dr. Brennan suggested." Sarah found herself in the unusual position of watching her civilian colleagues attempt to implement mass casualty protocols they had only read about in textbooks. The results were predictably chaotic. "No, no," she said, stepping forward as she watched two residents trying to move equipment. "The most critical cases stay in the trauma bays. Walking wounded and moderate injuries go to the improvised areas. You're putting a conscious burn victim ahead of someone with massive internal bleeding." Dr. Whitaker looked up from the patient he was examining. "How do you determine priority that quickly?" Sarah moved between the incoming stretchers with the fluid efficiency she had developed in Iraq, her hands briefly checking each patient while her eyes assessed injury severity, responsiveness, and immediate needs. "This one," she said, pointing to an unconscious construction worker, "has signs of severe head trauma. Trauma 3, immediately. This woman has a compound fracture but is stable. Waiting room, splint, and pain management. This teenager has possible internal bleeding but is responsive. Trauma 4, after we stabilize the head injury." She continued down the line of incoming casualties, making rapid triage decisions that probably saved several lives in the first 10 minutes of the crisis. "Dr. Brennan," Morrison called out, "I need you to take the lead on the most critical cases." Sarah paused, looking around the emergency department that now resembled a battlefield medical station more than a civilian hospital. Patients on stretchers filled every available space, medical staff moved between them with organized urgency, and the sound of multiple monitors created a constant background symphony of beeps and alarms. It was exactly the environment she had sworn to leave behind. "Sarah?" Morrison's voice cut through her momentary paralysis. She took a deep breath and nodded. "I'll need additional nurses, at least 2 more residents, and someone to coordinate supply distribution. We're going to run short on blood products if we don't manage inventory carefully." For the next 6 hours, Sarah demonstrated why Forward Surgical Team Alpha 7 had been considered one of the most effective military medical units in Iraq. She moved between patients with the same calm efficiency she had shown during Marcus Thompson's surgery, but now multiplied across dozens of cases. She performed an emergency thoracotomy on a bus driver whose lung had been punctured by steering wheel fragments. She stabilized a pregnant woman who had gone into premature labor due to crash trauma. She coordinated with orthopedic surgeons to repair multiple compound fractures on a family of 4 who had been trapped in their overturned sedan. Most remarkably, she did it all while maintaining the kind of systematic approach to mass casualty management that her colleagues had only theoretical knowledge of. "How's she doing this?" Dr. Chen whispered to Jennifer Torres as they watched Sarah simultaneously directing the treatment of 3 critical patients while personally operating on a 4th. "She's running this like a military operation," Torres replied. "Look at how she's positioned everyone, how she's managing supply flow. This isn't improvisation, this is training." As the night wore on, Sarah's military experience became impossible to hide. She used terminology that civilian doctors didn't recognize, implemented treatment protocols that weren't taught in medical school, and made resource allocation decisions with the kind of cold efficiency that comes from having managed medical logistics under fire.
"Dr. Brennan." Dr. Whitaker approached her during a brief lull around 3 a.m. "That technique you used to stabilize the pregnant woman, I've never seen anything like it." Sarah was reviewing patient charts, prioritizing who needed surgery next. "It's called damage control obstetrics. We used it when we had to deliver babies under combat conditions." "Combat conditions?" Whitaker's eyes widened. "You delivered babies in Iraq?" Sarah looked up from her charts, suddenly realizing how much she had revealed during the course of the night. "Among other things, yes. Civilian casualties don't stop being human just because there's a war going on. Before Whitaker could ask more questions, another ambulance arrived with 2 more critical patients from the accident scene. Sarah immediately shifted back into triage mode, but Whitaker continued watching her with new understanding. By dawn, the crisis was largely under control. 28 patients had been treated, 15 of them for critical injuries. 3 had required emergency surgery. 2 had been transferred to specialized burn units at other hospitals, and remarkably, only 1 had been lost, an elderly man who had suffered a massive heart attack during the initial collision and had likely died before the ambulances arrived. As the last patient was moved to the ICU, Sarah found herself alone in the emergency department for the first time in almost 8 hours. The space was being cleaned and reset for normal operations, but the evidence of the night's events was everywhere. Empty IV bags, discarded surgical instruments, bloodstains on the floor that the cleaning crew was methodically removing. She sat down in one of the chairs in the improvised waiting room triage area and allowed herself to feel the exhaustion that she had been suppressing all night. Her hands were shaking slightly, a delayed stress response she recognized from her military days. Dr. Morrison approached and sat down beside her. "How are you holding up?" Sarah was quiet for a long moment. "I keep thinking about Forward Surgical Team Alpha 7, about how we would debrief after big nights like this. Go through every case, every decision, figure out what we could have done better." "And what would your assessment of tonight be?" "We saved everyone we could reasonably save. Good outcomes, efficient resource utilization, no major mistakes. By military medical standards, it was a successful operation." Morrison nodded. "By any standards, it was remarkable. You probably saved at least 6 lives tonight with decisions and techniques that our other trauma surgeons wouldn't have known to use." Sarah looked around the emergency department, now being restored to its normal sterile calm. "The problem is, I enjoyed it." "What do you mean?" "I mean that, for the first time since I came back from Iraq, I felt like I was doing what I was trained to do. I felt useful, competent, necessary. And that scares me." Morrison frowned. "Why does that scare you?" Sarah stood up and walked to the window that looked out over the hospital parking lot where the last of the ambulances were departing. "Because in Iraq, there was always another convoy getting hit, always another IED going off, always another crisis that needed my skills. I got addicted to the adrenaline, to being the person everyone turned to when things went wrong." She turned back to face Morrison. "When I came home, I thought I wanted quiet. I thought I wanted routine surgeries and predictable outcomes. But tonight proved that what I really want is to be needed like this." "That doesn't sound like a problem to me. That sounds like someone who has found their calling." "My calling killed Kevin Walsh and cost Jennifer Kim her leg. My calling got 43 people I couldn't save. My calling means that I measure my success by how many people don't die on my watch." Morrison stood up and joined her at the window. "Sarah, what happened to your team in Iraq wasn't your fault. And what you did tonight, saving all those people, that's not just your calling, that's a gift." Sarah was quiet for several minutes, watching the sunrise begin to color the sky above the parking lot where the last of the ambulances were departing. "Dr. Morrison, I need you to ask me something, and I need you to be completely honest with me." "Of course." "Do you think I am more valuable to this hospital as a trauma surgeon than as a regular surgeon?" Morrison considered the question carefully. "I think you're exceptional at both, but your trauma skills are truly unique. What you did tonight, very few people in the world could have done as well." Sarah nodded slowly. "Then I think it's time I stopped trying to be someone I'm not." She walked toward the elevator, then paused and looked back. "Dr. Morrison, I want to accept your offer of a hybrid position, but I want to expand it." "How so?" I want to help you develop a comprehensive mass casualty protocol for this hospital. Real training for situations like tonight, not just theoretical preparation. And I want to train a team of nurses and residents in advanced trauma techniques. Morrison's eyes lit up. You're talking about creating a specialized emergency response capability. I'm talking about making sure that the next time something like this happens, more people are prepared to handle it. So the burden isn't all on one person who happens to have learned medicine in a war zone. As the elevator doors closed behind her, Sarah felt something she hadn't experienced since leaving Iraq, a sense of purpose that aligned with her abilities instead of fighting against them. The nightmares might never completely go away, but perhaps she could find a way to honor the 43 people she couldn't save by making sure she was better prepared to save the ones who came after.
3 months after the mass casualty event, Riverside General had become a different hospital. Sarah's proposal to develop comprehensive emergency response protocols had been approved by the hospital board with unprecedented speed, largely due to the glowing reports from the families of patients who had survived the highway collision. The transformation was visible throughout the medical center. What had once been a standard suburban hospital was now equipped with modular trauma stations that could be deployed rapidly during emergencies. Sarah had worked with the facilities team to redesign supply storage, creating what she called crisis caches, strategically located medical supplies that could support mass casualty operations without depleting routine surgical resources. But the most significant change was in the people. Sarah stood in the hospital's main conference room, addressing a group of 24 medical personnel who had volunteered for her advanced trauma response training program. The group included nurses, residents, attending physicians, and even several paramedics from the county emergency services who had requested permission to participate. Emergency medicine isn't just about individual patient care, she was explaining, using a large display screen to show casualty flow diagrams. When you're dealing with multiple critical patients simultaneously, you have to think in terms of systems, resources, and time allocation. Dr. Amanda Foster, a second-year resident, raised her hand. Dr. Brennan, how do you make life-or-death triage decisions so quickly? During the simulation last week, I froze when I had to choose between 2 critical patients. Sarah had been expecting this question. It was one that every military medical officer struggled with, and one that civilian doctors rarely had to face until they were thrust into crisis situations. The hardest lesson I learned in Iraq, she said, walking to the whiteboard, is that sometimes the most humane thing you can do is accept that you can't save everyone. She drew a simple diagram showing 3 categories: immediate, delayed, and expectant. In military medicine, we use a 3-tiered triage system. Immediate means the patient will die without intervention, but has a good chance of survival with treatment. Delayed means the patient needs care but can wait. Expectant means— She paused, looking around the room at faces that were still learning to process the realities of combat-level medicine. Expectant means the patient is likely to die regardless of treatment, and using limited resources on them means other patients with better chances won't get the care they need. The room was completely silent. Jennifer Torres, who had become Sarah's closest collaborator in developing the training program, spoke up from the back of the room. How do you live with making those decisions? Sarah set down the marker and leaned against the desk. You focus on the math instead of the emotion. If I have 1 surgical team and 2 patients who need immediate surgery, one with a 90% chance of survival and one with a 20% chance, the choice is clear from a utilitarian perspective. But what about from a human perspective? Asked Dr. Michael Barnes, an emergency medicine attendant who had initially been skeptical of Sarah's methods. From a human perspective, it's devastating, Sarah replied honestly, but the alternative is letting both patients die while you debate ethics. She walked to the front of the room and pulled up a new slide showing casualty statistics from the recent highway accident. During the mass casualty event 3 months ago, we had 28 patients and limited resources. If we had tried to give equal attention to everyone, we would have lost at least 6 people who ultimately survived. The triage decisions we made, prioritizing patients with the best chance of survival, saved lives. Dr. Foster looked troubled. But doesn't that mean we're essentially playing God? No, Sarah said firmly. Playing God would be making decisions based on personal judgment about who deserves to live. Triage is making decisions based on medical facts about who has the best chance of living. She clicked to the next slide, which showed photographs of the survivors from the highway accident. Marcus Thompson, now fully recovered with his family, the pregnant woman who had delivered a healthy baby, the teenage boy who had returned to school. These people are alive because we made hard choices quickly and efficiently. That's not playing God, that's practicing medicine under extreme circumstances. The training session continued for another 2 hours, covering everything from battlefield surgical techniques to resource management during extended crisis situations. Sarah had adapted her military medical knowledge for civilian application, but the core principles remained the same: speed, efficiency, and calculated decision-making under pressure. After the session ended, Sarah was gathering her materials when Captain Rodriguez appeared in the doorway. She hadn't seen him since their conversation months ago, but his presence immediately put her on alert. "Captain Rodriguez," she said neutrally, "what brings you to Riverside?" "Can we talk privately?" he asked, glancing around the conference room where several participants were still discussing the day's lessons. Sarah nodded and led him to her office, a small space she had been given when she accepted the expanded trauma coordinator position. The walls were covered with surgical technique diagrams and emergency response flowcharts, but notably absent were any personal photographs or military memorabilia. "How are you adapting to your new role?" Rodriguez asked as he settled into the chair across from her desk. "Better than I expected," Rodriguez replied cautiously. "The training program has been well received, and we've already implemented several protocol improvements based on lessons learned from the mass casualty event." Rodriguez nodded approvingly. "I've heard excellent reports about what you're doing here. Word has spread through the VA medical community about your innovative approaches to civilian trauma care."
Sarah felt a familiar tension building in her shoulders. "Captain, why do I get the feeling this isn't a social visit?" Rodriguez leaned forward, his expression becoming more serious. "Dr. Brennan, I'm here because the military has taken notice of your work. Specifically, the Army Medical Research Command has been reviewing the protocols you've developed here at Riverside." "What kind of review?" "The kind that results in requests for consultation," Rodriguez replied. "They want you to help develop new training programs for military medical personnel transitioning to civilian practice." Sarah's hands, which had been resting calmly on her desk, clenched into fists. "I'm not interested in returning to military medicine, even in a consulting capacity." "This wouldn't be military medicine," Rodriguez explained quickly. "It would be using your experience to help other veterans make the transition you've made, teaching them how to adapt their combat medical skills to civilian hospitals." Sarah stood up and walked to the window that looked out over the hospital parking lot, the same view she had contemplated during many difficult decisions over the past months. "How many veterans are we talking about?" she asked. "Currently, there are approximately 400 former military medical personnel who have completed their service and are transitioning to civilian careers. Many of them are struggling with the same issues you faced: how to use their specialized skills in environments that don't understand their background." Sarah turned back to face him. "And the military thinks I'm qualified to help them because I've figured out how to manage my own transition?" "The military thinks you're qualified because you've not only managed your own transition, but you found a way to make your combat experience an asset rather than a liability," Rodriguez corrected. "What you've built here, this training program, these protocols, it's exactly what other transitioning veterans need to see." Sarah returned to her desk but remained standing. "What exactly would they want from me?" Rodriguez opened his briefcase and pulled out a thick folder. "They want you to develop a standardized curriculum for integrating combat medical experience into civilian trauma programs. Think of it as a reverse of what you've done here. Instead of adapting combat medicine for civilian use, you'd be teaching civilian hospitals how to benefit from hiring veterans with combat medical experience." He placed the folder on her desk. "The financial compensation would be substantial, and you'd be helping veterans who are dealing with many of the same challenges you faced." Sarah looked at the folder but didn't pick it up.
And the commitment? Initial contract would be for 2 years, part-time consultation. You'd continue your work here at Riverside while developing the curriculum. Travel would be minimal, mostly virtual conferences and occasional site visits to participating hospitals. Participating hospitals. The program would start with 12 major trauma centers across the country that have agreed to pilot integration programs for veteran medical personnel. If successful, it would expand nationally. Sarah finally picked up the folder and opened it, scanning the initial documents. The scope of the program was larger than she had imagined. Comprehensive training modules, veteran placement services, ongoing support systems for both the veterans and the civilian hospitals employing them. "This is ambitious," she said, looking up at Rodriguez. "It's necessary," he replied. "Too many talented medical veterans are struggling to find their place in civilian medicine. Some of them are leaving the field entirely rather than fight the perception that military medical experience doesn't translate to civilian care." Sarah closed the folder and set it aside. "Can I ask you something, Captain?" "Of course." "Why me? There have to be other veterans who have made successful transitions, people with more seniority or better connections." Rodriguez smiled slightly. "Because most successful transitions are quiet. People like you usually disappear into civilian careers and never talk about their military experience again. You're one of the few who has found a way to openly integrate that experience into civilian practice." He stood up to leave, then paused at the door. "Dr. Brennan, I want you to know that what you've accomplished here isn't just personally impressive, it's professionally groundbreaking. The protocols you've developed could save thousands of lives if they were implemented nationally." After he left, Sarah sat alone in her office, staring at the folder. Through her window, she could see the emergency department where Marcus Thompson had first revealed her true capabilities, where the mass casualty event had forced her to fully embrace her combat medical training. Her phone buzzed with a text message from Dr. Morrison. "Sarah, we just received notification that Riverside has been selected as a Level 1 trauma center, effective immediately. Your training programs were specifically cited as a determining factor. Congratulations." Sarah set down her phone and opened the folder again, this time reading more carefully. The proposed program would affect hundreds of veterans, dozens of hospitals, and potentially thousands of patients who would benefit from improved trauma care. She thought about Forward Surgical Team Alpha 7, about Kevin Walsh and Jennifer Kim, about the 43 patients she couldn't save. For years, she had carried those memories as burdens, weights that held her back from fully engaging with her medical career. But perhaps there was another way to honor those memories. She picked up her phone and dialed Captain Rodriguez's number. "Captain, it's Dr. Brennan," she said when he answered. "I want to discuss the consultation proposal, but I have some conditions of my own." "I'm listening." "First, any veteran who participates in this program gets access to comprehensive mental health support, not just career placement assistance. That can be arranged."
Second, the curriculum includes specific modules on managing PTSD and combat-related stress in medical settings. Also feasible. Sarah took a deep breath. "And third, I want Jennifer Kim involved in developing the program. She's the anesthesiologist who lost her leg in Iraq. If we're going to help veterans transition to civilian medicine, we need input from someone who's had to rebuild their entire approach to their medical career." There was a pause on the other end of the line. "Dr. Brennan, that's an excellent suggestion. I'll make some calls." After ending the conversation, Sarah walked back to the window and looked out at the hospital where she had finally found a way to be both the person she had become in Iraq and the person she wanted to be at home. For the first time since returning from combat, she felt like her military service and her civilian career weren't competing with each other. They were collaborating towards something larger than either could accomplish alone. 6 months into the Veteran Integration Program, Sarah found herself in an unexpected place. The auditorium of Walter Reed National Medical Center, preparing to address an audience of 200 military medical personnel who were transitioning out of active duty. The irony wasn't lost on her. 3 years earlier, she had left the military determined never to set foot in a military hospital again. Now she was here voluntarily, about to share the lessons she had learned about bridging the gap between combat medicine and civilian healthcare. Dr. Brennan, Colonel Patricia Hayes approached her backstage. Sarah recognized her immediately, her former commanding officer from Forward Surgical Team Alpha 7, though the years had added gray to her hair and new lines around her eyes. "Colonel Hayes." Sarah stood and saluted instinctively, then caught herself and extended her hand instead. "It's good to see you again." Hayes smiled and shook her hand. "It's General Hayes now, actually. And it's good to see you too, Sarah. I've been following your work at Riverside General with great interest. I heard about your promotion. Congratulations." "Thank you. More importantly, I wanted to personally thank you for what you're doing with this program. We've needed something like this for years." They were interrupted by Jennifer Kim, who wheeled herself over to join them. Sarah had been working with Jennifer for months now, but seeing her former colleague in a military hospital brought back a flood of memories from their time together in Iraq. "Jennifer," Sarah said warmly, embracing her friend, "how are you feeling about today?" "Nervous," Jennifer admitted. "It's one thing to develop training materials from an office in Denver. It's another thing to stand in front of 200 veterans and tell them how to cope with civilian medicine." Jennifer had become an integral part of the program, developing specialized protocols for medical personnel dealing with physical disabilities acquired during their service. Her perspective as someone who had to completely reimagine her approach to anesthesiology after losing her leg had proven invaluable. "You'll be fine," Sarah assured her. "Just remember, everyone in that audience has been where we've been. They understand the challenges better than anyone." General Hayes checked her watch. "Ladies, it's time. Are you ready?" As they walked toward the stage, Sarah reflected on how much had changed since that day when Dr. Whitaker had questioned her experience with combat trauma. The Veteran Integration Program had expanded beyond her wildest expectations, now operating in 37 hospitals across 22 states. More than 100 former military medical personnel had successfully transitioned to civilian positions, and patient outcomes at participating hospitals had improved dramatically. But the real measure of success, Sarah had learned, wasn't in the individual stories of veterans who had found their place in civilian medicine. The auditorium fell silent as Sarah approached the podium. Looking out at the audience, she saw faces that reminded her of her younger self. Military medical personnel who had served with distinction but were uncertain about their future in civilian healthcare. 3 years ago, she began, I was sitting in an audience very much like this one, listening to a transition counselor explain how to translate military experience into civilian resume language. I was told to emphasize my technical skills and de-emphasize my combat experience because civilian employers wouldn't understand the relevance of battlefield medicine. Murmurs of recognition rippled through the audience. That counselor was wrong, Sarah continued, not because civilian employers automatically understand military experience, but because hiding your background doesn't serve anyone, not you, not your future patients, and not the healthcare system that desperately needs what you have to offer. She clicked to her first slide, which showed before and after statistics from Riverside General's trauma program. When I started at Riverside General, I was determined to be a normal civilian surgeon. I wanted routine cases, predictable schedules, and patients who came in for elective procedures. For 6 weeks, I succeeded in being exactly the kind of unremarkable doctor I thought I wanted to be. She clicked to the next slide, showing a photograph of Marcus Thompson with his family. Then Marcus Thompson came into our emergency department with massive abdominal trauma from a construction accident, and everything changed. Not because I wanted it to, but because when someone's life is on the line, you use every tool at your disposal, including tools you learned in places you'd rather forget. Sarah looked out at the audience, making eye contact with individuals in the crowd. How many of you have been told that your military medical experience won't translate to civilian practice? Nearly every hand in the auditorium went up. How many of you have been advised to minimize your combat experience when applying for civilian positions? Again, almost a universal response. And how many of you believe that advice is wrong? This time, the response was more hesitant but still significant.
Sarah clicked a new slide showing the organizational chart of the Veteran Integration Program. The program we've developed isn't just about finding jobs for military medical personnel, she explained. It's about transforming civilian healthcare by demonstrating the value of combat medical experience. She introduced the key components: mentorship programs pairing veteran medical personnel with experienced civilian practitioners, specialized training modules that helped veterans adapt their skills to civilian protocols, and, perhaps most importantly, education programs that taught civilian hospitals how to recognize and utilize the unique capabilities that veterans brought to healthcare teams. Dr. Jennifer Kim, my former colleague from Iraq, will now share her experience with adapting anesthesiology practice after a combat-related injury, Sarah said, stepping aside to make room for Jennifer's wheelchair at the podium. Jennifer's presentation was powerful in its honesty. She described the challenges of relearning her profession after losing her leg, but also the unexpected advantages her combat experience had given her in managing complex cases and crisis situations. Losing my leg forced me to completely rethink how I practice anesthesiology, Jennifer explained. But my combat experience taught me that adaptation isn't just possible, it's essential. The techniques I developed for managing anesthesia in austere environments have made me a better anesthesiologist in civilian hospitals, not despite my military experience, but because of it. When Jennifer finished, Sarah returned to the podium for the final portion of the presentation. "I want to share something with you that I've never discussed publicly before," she said, her voice taking on a more personal tone. "During my second tour in Iraq, I started keeping a list. Not of the patients we saved, I kept that list too, but of the patients we lost." The auditorium was completely silent now. 43 names, ages, causes of death. For years after coming home, I carried that list as evidence of my failures, proof that I wasn't as good as people thought I was. She clicked to a new slide that simply showed the number 43 in large font. It took me 3 years to understand that I was looking at that list all wrong. Those 43 people didn't die because I failed. They died because they were in an impossible situation. But every technique I learned trying to save them, every protocol we developed under pressure, every innovation we made with limited resources, those lessons have helped me save dozens of patients in civilian practice. She clicked to the final slide, which showed a group photograph of the current staff at Riverside General's Trauma Department. "This is my team at Riverside General. Dr. Amanda Foster, who was a second-year resident when I started, is now one of the most capable trauma surgeons in the state, because she learned techniques I brought back from Iraq. Jennifer Torres, our head trauma nurse, has trained dozens of other nurses in protocols we adapted from military medicine. Dr. Michael Barnes, who initially questioned my methods, now advocates for hiring veterans specifically because of the unique perspective they bring to emergency medicine." She paused, looking out at the audience of veterans who were preparing to make the same transition she had made. The civilian healthcare system doesn't just need you, it needs what you've learned, what you've survived, and what you've become because of your military experience. The question isn't whether your combat medical training is relevant to civilian practice. The question is whether civilian medicine is ready to learn from what you have to teach. The applause that followed was sustained and emotional. Sarah could see in the audience's faces that had shifted from uncertainty to determination, from hiding their backgrounds to embracing them. During the question and answer session that followed, the inquiries were substantive and practical. Veterans wanted to know about specific techniques for presenting their experience to civilian employers, strategies for managing PTSD symptoms in high-stress medical environments, and resources for continuing education that would help them bridge military and civilian medical practices. But the most impactful moment came near the end, when a young Army medic stood up in the back of the auditorium. "Dr. Brennan," he said, his voice carrying across the large space, "I was at the aid station in Kandahar when you performed that emergency surgeon on Sergeant Williams after the IED attack in 2020. You saved his life, and watching you work is part of what made me want to become a doctor." Sarah felt her breath catch. She remembered the case, a complex abdominal surgery performed under incoming fire, one of the most challenging procedures she had completed during her second tour. "Sergeant Williams is my older brother," the medic continued. "He's alive today because of what you did. I just wanted you to know that your combat experience didn't just prepare you for civilian medicine, it prepared me for it too." The auditorium erupted in applause again, but Sarah barely heard it. She was remembering that night in Kandahar, the sound of mortar rounds impacting outside their surgical tent, the intense focus required to save a life while explosions shook the ground beneath her feet. For years, she had carried that memory as one of many traumatic experiences she wanted to forget. Now, suddenly, it had become something else entirely. A moment when her skills had not only saved a life, but inspired someone else to pursue a career in medicine. After the presentation ended, Sarah found herself surrounded by veterans asking for additional advice, sharing their own stories, and expressing gratitude for a program that finally acknowledged the value of their military medical experience. As the crowd began to disperse, General Hayes approached her again. "Sarah, I have a proposition for you," she said. "The Surgeon General's office has been monitoring the success of your program, and they want to expand it internationally. We have NATO allies who are dealing with similar issues as their military medical personnel transition to civilian careers." Sarah looked around the auditorium, where small groups of veterans were still engaged in animated discussions about their future plans. "What would that involve?" she asked. "Initially, consultation with medical systems in the UK, Canada, and Australia. Eventually, potentially developing programs for countries that have participated in coalition operations and are facing similar transition challenges." Sarah considered the proposal. 6 months earlier, the idea of expanding her involvement with military medicine would have filled her with anxiety. Now, it felt like a natural evolution of work she had already committed to. "I'll need to discuss it with my team at Riverside," she said finally, "but I'm interested." As she gathered her materials and prepared to leave Walter Reed, Sarah reflected on the journey that had brought her to this moment. She had started as a surgeon trying to hide from her military experience and had become someone who was helping transform how the medical profession understood the value of combat medical training. The nightmares still came sometimes, and the memories of patients she couldn't save would never completely fade. But now those experiences were balanced by new memories. Veterans finding successful careers in civilian medicine, trauma programs saving more lives, and a growing recognition that military medical experience wasn't something to be hidden, but something to be celebrated and utilized. Walking through the corridors of Walter Reed, past photographs of military medical personnel who had served in conflicts dating back decades, Sarah realized that she had finally found a way to honor both the person she had been in Iraq and the person she had become at home. She was no longer fighting against her past. She was building on it. 1 year later, Sarah stood in the observation deck of Riverside General's new trauma simulation center, watching a group of residents practice mass casualty protocols. The facility, funded partially by a Department of Defense grant and partially by the hospital's own investment in veteran integration programs, represented everything she had hoped to achieve when she first proposed expanding trauma training. Below her, Dr. Amanda Foster was leading a simulation exercise involving a simulated terrorist attack with multiple casualties. The residents moved through triage protocols with the kind of systematic efficiency that would have been impossible before Sarah's program began. More importantly, 3 of the residents participating were themselves military veterans, seamlessly integrating their combat experience with civilian medical training. Impressive, isn't it? Dr. Morrison joined her at the observation window, carrying 2 cups of coffee. Sarah accepted the coffee gratefully. It's what we always hoped it could become. But seeing it actually work. She trailed off, watching as the simulation team successfully stabilized all the simulated casualties within the prescribed time frame. "Any regrets about the international expansion?" Morrison asked. Sarah smiled slightly. The NATO Medical Integration Program had launched 3 months earlier, with Sarah spending considerable time consulting with hospitals in London, Toronto, and Sydney. The work was demanding and required frequent travel, but the results had exceeded everyone's expectations. "None," she replied, "though I never imagined I'd be training British Army medics how to adapt to the NHS." Through the observation window, they could see the simulation winding down. Dr. Foster was conducting the post-exercise debrief, going through each decision point and discussing alternative approaches. It was exactly the kind of systematic analysis that Sarah had learned to value during her military service. "Dr. Brennan?" A voice behind her made Sarah turn around. Standing in the doorway was Marcus Thompson, the construction worker whose near-death experience had first revealed Sarah's true capabilities. He was accompanied by a young woman in scrubs who bore a strong resemblance to him. "Marcus," Sarah said with genuine warmth, walking over to shake his hand. "How are you feeling?" "Better than ever," he replied with a grin. "Dr. Morrison said I could find you here. I wanted you to meet someone." He gestured to the young woman beside him. "This is my daughter, Lisa. She just finished her first year of nursing school, and she's applied for your trauma training program." Sarah looked at Lisa with interest. The young woman had the same determined expression that Sarah recognized in all the best medical personnel she had worked with. "What made you interested in trauma nursing?" Sarah asked. Lisa glanced at her father, then back at Sarah. "Watching what you did for my dad changed how I think about emergency medicine. I realized that trauma care isn't just about medical knowledge. It's about staying calm under pressure and making good decisions when everything is chaotic." "That's exactly right," Sarah agreed. "And your application?" "Accepted," Dr. Morrison interjected with a smile. "She starts the program next month." As Marcus and Lisa left to tour the simulation center, Sarah reflected on the unexpected connections that had emerged from her work. Marcus Thompson's daughter was just one of dozens of young medical professionals who had been inspired by the integration program to pursue careers in emergency medicine. Her phone buzzed with a text message from Jennifer Kim. "Sarah, turn on Channel 7 News. You need to see this." Sarah pulled up the news stream on her phone just as a breaking news report began. The anchor was standing outside a hospital in Phoenix, Arizona. Thanks to new trauma protocols developed by military medical veterans, doctors at Phoenix Memorial Hospital were able to save all 17 victims of today's multi-vehicle accident on Interstate 10. Hospital officials credit training programs that integrate combat medical techniques with civilian emergency care. The report continued with interviews from doctors at Phoenix Memorial, one of the hospitals participating in the Veteran Integration Program. Dr. Sarah Martinez, a former Navy surgeon, described how military-derived triage protocols had allowed them to handle the large number of casualties efficiently.
"Dr. Brennan," Dr. Morrison said, looking up from her own phone, "you're getting calls from 3 different news networks. Word about today's success in Phoenix is spreading fast." Sarah put her phone away without answering the calls. "Let the Phoenix team take the credit. They did the work." "Sarah," Morrison said gently, "you need to accept that you've created something bigger than yourself. These protocols, this training program, they're saving lives across the country now." Before Sarah could respond, Captain Rodriguez appeared in the observation deck doorway, accompanied by a woman Sarah didn't recognize. "Dr. Brennan," Rodriguez said, "I'd like you to meet Dr. Catherine Walsh." Sarah's breath caught. The name was familiar. Dr. Kevin Walsh had been her replacement at Forward Surgical Team Alpha 7, the surgeon who had been killed in the attack 3 months after she left. "Kevin was my brother," Dr. Walsh said simply, extending her hand to Sarah. Sarah shook it, unsure how to respond. "I'm sorry for your loss. Kevin was an exceptional surgeon." "He was," Catherine agreed. "But I'm not here about that. I'm here because I've been following your work, and I have a proposal." She opened a tablet and showed Sarah a presentation slide titled, "The Walsh Foundation, Advancing Combat Medical Research." "My family has established a foundation to fund research into translating combat medical innovations to civilian healthcare. We want to endow a research chair at a major medical university, specifically focused on trauma care innovations derived from military medicine." Sarah looked at the presentation, which outlined a comprehensive research program that would systematically study and improve the techniques she and others had developed. "We want you to be the first Walsh Chair in Combat Medical Innovation, based here at Riverside, but with research collaborations at universities nationwide." Sarah was quiet for a long moment, processing the offer. A research chair would mean tenure, substantial funding for her work, and the opportunity to formalize much of what she had been developing through practical experience. "Why me?"
she asked finally. Catherine smiled, and for a moment, Sarah could see the family resemblance to her brother. Because Kevin wrote about you in his last letter home. He said you were the most innovative trauma surgeon he had ever worked with, and that he hoped someday he could be half as good as you were at saving lives under impossible circumstances. Sarah felt tears she hadn't expected forming in her eyes. I didn't know he felt that way. Kevin believed that the techniques you developed in Iraq could revolutionize civilian trauma care if they were properly studied and refined. This foundation is our way of making sure that happens. Dr. Morrison stepped forward. Sarah, Riverside would be honored to host the research chair. We could expand the simulation center, add research laboratories, and create a comprehensive trauma innovation program. Sarah walked back to the observation window, looking down at the simulation center where another group of residents was beginning their training exercise. She thought about the path that had brought her here, from a young surgeon trying to hide her military experience to someone who was helping transform emergency medicine on an international scale. There's one condition, she said, turning back to Catherine Walsh. What's that? The research program has to include comprehensive mental health support for veterans participating in civilian medical integration. We can't just focus on the technical aspects. We have to address the psychological challenges too. Catherine nodded immediately. That's exactly what Kevin would have wanted. As the group discussed the details of the research chair, Sarah realized that she had finally found a way to honor all the memories she carried. The 43 patients she couldn't save, Kevin Walsh and the others who died serving, and the hundreds of patients whose lives had been saved by techniques developed under combat conditions. 6 months later, Sarah stood once again in a familiar place, the trauma bay at Riverside. But this time, she wasn't treating patients. She was conducting research, documenting protocols, and training the next generation of trauma surgeons who would carry these innovations to hospitals around the world. The trauma alert sounded, and Sarah watched as her team responded with the kind of coordinated efficiency that had become standard at Riverside. Dr. Amanda Foster led the response. Dr. Lisa Thompson assisted as part of her advanced training, and the entire process was documented for research purposes. As the patient was stabilized and moved to surgery, Sarah made notes on her tablet about the techniques used and their effectiveness. But more than that, she felt a sense of completion that had eluded her for years. She had finally found a way to transform her combat experience from a source of trauma into a tool for healing, not just for herself, but for the countless patients who would benefit from the innovations that emerged from military medical experience. The nightmares still came occasionally, and she still remembered every name on her list of 43. But now, those memories coexist with new ones. Veterans finding their place in civilian medicine, trauma programs saving more lives, and a growing understanding that military medical experience wasn't something to be overcome, but something to be celebrated and shared. As she left the hospital that evening, Sarah passed the memorial wall that had been installed near the trauma center entrance. Among the plaques honoring medical personnel who had served in various conflicts was one that read, "Dedicated to all military medical personnel who continue serving by sharing their knowledge and experience with civilian healthcare." Below it was a simple inscription, Salvare Vitas, save lives. Sarah smiled as she read it, knowing that Forward Surgical Team Alpha 7's motto had found new life in a place Kevin Walsh and the others would have been proud to see it, not on a battlefield, but in a hospital where their legacy lived on in every life saved through techniques learned under fire and refined through research. She had come full circle, from combat surgeon to civilian doctor to researcher and teacher. But most importantly, she had learned that honoring the past didn't mean being trapped by it. It meant using it to build something better for the future. Up next, you've got 2 more standout stories right on your screen. If this one hits the mark, you won't want to pass these up. Just click and check them out. And don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.